I'm Dr. Sabrina Siegel with the Neuroscience Education Institute, and twice a month I sit down with a renowned mental health care expert to discuss breakthroughs and best practices for treating patients with mental illness. In this episode of the NEI podcast, I have the pleasure of interviewing NEI's Chief Medical Officer, Dr. Andrew Cutler, as we take a look back in the year of 2019 and we reflect on the most exciting news in psychopharmacology. Going back, and I know you touched on this a little bit, the exciting findings on ketamine. What are some of the most recent research findings on ketamine that were reported earlier this year, particularly with respect to mood disorders?
Right. Well, of course, as I mentioned, ketamine has been shown to be very effective, and there's a lot of research being done with ketamine and with S-ketamine as well. And one of the things that's being looked at is S-ketamine for acute suicidality, the S-ketamine intranasal spray. What happens traditionally with antidepressant trials or mood disorder trials is we tend to exclude patients that have suicidal ideation or suicidal behaviors. And so we don't know a lot about the effectiveness of most of our antidepressant medications for acutely treating suicidality. And of course, this is hugely important. As a matter of fact, our antidepressants all carry warnings about possible increase in suicidal ideation and behavior. So S-ketamine is being looked at for this, and there is some preliminary data that it might be effective. Also, S-ketamine was looked at in a recent phase 3 study, plus added to an oral antidepressant, and this was a long-term maintenance trial. And what is very important here is that sometimes medications that work acutely don't always hold a charge or don't always continue to work over a long period of time. And particularly a medicine like ketamine or S-ketamine, which is rapidly acting and which we have to give frequently, these treatments. The question is, how long do they hold a charge, and how long do we have to keep giving them? Well, in this long-term maintenance trial or relapse prevention study, it was shown that patients who got S-ketamine and continued with S-ketamine after 16 weeks were much less likely, 51% less likely to relapse if they'd achieved stable remission, and 70% if they achieved a stable response, 70% less likely to relapse. So this is really important because it's the first to be reported from a controlled maintenance study on S-ketamine plus an oral antidepressant versus placebo plus an oral antidepressant alone. Now, also, subanesthetic doses of ketamine have demonstrated rapid yet transient effects on patients with treatment-resistant depression. So ketamine has been looked at not only in regular depression, if you will, but treatment-resistant depression. And I did mention earlier that S-ketamine was studied and is approved for treatment-resistant depression, and this is defined as failing 2 or more antidepressants in the current episode of depression. Now, in a recent study with ketamine, this is not S-ketamine, a single-site randomized double-blind crossover study, antidepressant effects of a single ketamine dose, a series of ketamine infusions, and maintenance infusions were looked at in 41 patients with TRD. And patients got single infusions of ketamine or midazolam as a sort of an active control, if you will. And we know that midazolam can have some psychoactive effects, but is not thought of as an antidepressant. After relapse of depressive symptoms, patients received a course of 6 open-label ketamine infusions 3 times weekly over 2 weeks. So again, frequent administration. After 24 hours, a single dose of ketamine resulted in a significantly greater reduction in depression compared to midazolam. And post-analysis revealed cumulative antidepressant effects with repeated infusions and doubling of the antidepressant response rate. Nearly 60% of these people met response criteria after repeated infusions. People needed a median of 3 infusions before meeting these criteria. So this was really a significant finding on how to use ketamine and how effective it can be, especially for TRD.
Thank you so much for sharing that with us. What were some of the most influential findings reported on anxiety and stress disorders this year?
Well, and a very important study was reported out this year that had to do with mild traumatic brain injury and comorbid conditions. This was a study that had a large number of patients, 1,155 patients with traumatic brain injury, and 230 patients that had orthopedic injuries that didn't involve the head. So that's an interesting way of controlling orthopedic injuries not involving the head. And patients with traumatic brain injury were more likely to report PTSD or major depressive symptoms at 3 and 6 months post injury. This is not necessarily surprising, something that we know is an association. But when you looked at this, the risk of major depressive disorder was 20% versus 8.7% of people who had orthopedic injuries not related to the head. And that was at 3 months. At 6 months, it was 21% versus 12% for those with traumatic brain injury versus other orthopedic injuries. And PTSD and MDD symptoms were assessed using standardized rating scales. And risk factors included pre-injury and injury characteristics. So patients with TBI who had some pre-injury factors, such as prior mental health problems or certain specific kinds of injury-related characteristics like assault or violence, had an even further increased risk of mental health issues. So this is something that it's something that we know about, but I don't think gets enough attention, especially when you consider the epidemic of traumatic brain injury that we're facing in this country, both from returning people from our overseas wars, but also from motor vehicle accidents, assaults, sports-related injuries, and others.
So, you discussed some of the novel medications that were approved for ADHD this year. What about research on some other therapeutic approaches? Were there any influential research studies this year that you'd like to share with us?
Absolutely. In addition to the new device that was approved as well, and the therapeutic video game that I mentioned earlier, believe it or not, saffron was studied for ADHD this year. And saffron, of course, we know is a delicious spice that is used in certain kinds of foods. But saffron is known as Crocus sativus, and it's reported to have antidepressant, anticonvulsant, anti-anxiety, pro-cognitive, and potentially neuroprotective effects. We are learning more and more that some of our effective treatments are neuroprotective and or neuroplastic, meaning they increase synaptogenesis or the connections of various neurons. We certainly think that that's part of how ketamine works so rapidly as an antidepressant. Well, saffron, believe it or not, might have some of these effects. And given the fact that it also has inhibitory actions at dopamine and norepinephrine reuptake pumps, so it has some DAT and NET inhibition, it also has some mild antagonist actions at NMDA, which is thought to be how ketamine can work, and some agonist actions at GABA A receptors. Well, guess what? That's how I mentioned that Sage 217 drug, which is being studied for depression, also works. So there was a recent study looked at saffron to treat ADHD. This was a pretty good sized study. This is 50 patients ages 6 to 12 with ADHD. And the researcher was named Baziar, Baziar, and he and his colleagues found that 20 to 30 milligrams a day of purified saffron extract was as effective at reducing both inattentive and hyperactive impulsive symptoms of ADHD as was 20 to 30 milligrams a day of methylphenidate, which is quite remarkable because that's a stimulant. During this study, it was a 6-week study. There were really no significant differences in either the clinician ratings or parent or teacher ratings between saffron and methylphenidate. Side effects, of course, as you would expect, were far less common with saffron than with the methylphenidate. So this is really exciting. We're talking about something that's potentially cost-effective, although it would be important to probably not just use saffron off the shelf. There probably needs to be a purified version available. And it's also a non-stimulant and not a controlled substance, and it would not be divertible or abusable potentially. So this, in addition to the non-stimulant that I mentioned that's in development called viloxazine ER, this is really exciting because for many years, all we had that was really effective were stimulants for ADHD.
Wow, that's so exciting. I understand that there was some novel research conducted on melatonin earlier this year. Would you share some of that with us?
Yes, melatonin, of course, we think of as improving our sleep-wake cycle. Melatonin is a naturally occurring hormone produced by the pineal gland that is helpful in the circadian rhythm. It's your brain's way of saying, hey, it's time to get ready for bed. And what happens is, as the sun goes down and it becomes dark, that's transmitted through the optic nerve to the pineal gland, and the darkness is a signal to release a burst of melatonin, which tells you time to get sleepy, time to get ready for bed. Well, so we've known for many years that melatonin is useful in that regard, but melatonin, it turns out, has many other far-reaching effects in the brain. And there was a recent study looking at melatonin, believe it or not, for Alzheimer's disease, and in particular, its effects on Alzheimer's neuropathology was studied. And the thinking is that melatonin can reduce amyloid pathology by increasing alpha secretase activity and decreasing beta secretase activity. Melatonin reduces activity of kinases, glycogen synthase kinase 3 or GSK3, and protein kinase A or PKA, and this is thought to lead to a reduction in the phosphorylation of tau protein, and consequentially a reduction in the formation of the neurofibrillary tangles, which we know are seen in Alzheimer's brains, and it's thought that these induce a serious inflammatory response that damages neurons. Melatonin by itself, speaking of which, has been shown to be anti-inflammatory and have antioxidative actions. Melatonin may improve cognition via improved LTP, long-term potentiation, and may help with the sundowning behavior, which is the irritability and agitation and exacerbation of neurobehavioral symptoms that are seen as the sun goes down in the late afternoon, early evening, that is often seen patients with AD and can cause real behavioral problems for caregivers and also in nursing homes and long-term care facilities. Unfortunately, we know that melatonin levels decrease with age and are even lower among patients with Alzheimer's. So this is very exciting that this might be a very low cost and low toxicity treatment that might help patients with Alzheimer's.
That's so exciting. I just have one final question for you as we wrap up our reflection on this year in psychopharmacology in 2019. What are some interesting announcements in psychopharmacology? One in particular having to do with the influence of social media on mental health. Can you speak to that?
Yeah, this is so timely and so important. Personally, as the parent of 15 and 13-year-old sons who are heavily involved with social media, I recognize the importance of this and it has personal impact. But there was a recent cohort study that found that 30 minutes or more a day of social media use was associated with more depression and anxiety, as well as bullying and attentional problems in adolescence. So, I want to step back and say that social media has been a wonderful development in helping people communicate and connecting people all across the globe. But we know, like anything else that's potentially good, if it's overused, there's also potentially a downside. And so this study, I think, was very important in showing potentially some of the risks. Like anything else, there are potential risks. And so in this case, there is a risk if people spend too much time involved with social media that there's more depression and anxiety, bullying, attentional problems, and social isolation, which we know that isolation can lead to more depression and even to risk for suicide.
Wow. Well, thank you so much for being on the show. And it has been a pleasure interviewing you on the highlights in psychopharmacology for 2019.
Well, I'm just thrilled to be here, and it really was a very exciting year. I look forward to even more exciting developments next year.
Yes. Thank you.
This episode has been brought to you by NEI Synapse. Register now to take advantage of early bird rates. They'll only last through January 15th, 2020. So grab your seat now. Go to www.neiglobal.com. We'll see you there.